All right, so this webinar is being recorded this morning and will be posted to the DMAS YouTube channel later this week. The name of that YouTube channel is Virginia Medicaid. If you are not subscribed to that, I would recommend doing that. There's some really great videos and trainings on there. A link to that video on YouTube will also be posted on the DMAS website, as well as a PDF of the presentation later this week as well. You can go to the Behavioral Health DMAS webpage, and there's a resource tab on that webpage, and that is where this information will be. But you can get the recording on YouTube probably as soon as tomorrow once I upload it. All participants are muted throughout the presentation and the Q&A. We will be taking Q&A only in the Q&A function. The chat is going to be enabled but will not be monitored. So if you have a specific question, you need to find the Q&A function and put your question into the Q&A. We'll be retaining all of those questions. Some of them we may be able to answer at this moment. Some of them will require some more collaboration between DMAS and DBHDS after the webinar. We will be creating a Q&A or an FAQ between both agencies. That'll be a collaboration, and that will be posted at a later date on both of our websites. If you need closed captioning, there is a closed captioning button, and please enable that so that you can read through what we are seeing. All right. So I am going to introduce our speakers today. I do want to point out that there are many individuals, including yourselves, who have been working hard to get our new crisis system across the state up and running over the last 2 years. We are just a few of those individuals. There are a lot of behind the scenes individuals that are working on this, as well as all of our providers who have been working hard in our regional hubs. Today, you're going to hear from Kurt Gleason. He's the Assistant Commissioner of Crisis Services at the Department of Behavioral Health and Developmental Services. You may hear from Bill Howard, who is the Director of Crisis Service Operations at DBHDS. And you also will hear from Dr. Lisa Jobe Shields, our Behavioral Health Division Director here at Medicaid, and myself, who is the Behavioral Health Senior Program Advisor. So good morning, everyone. Good morning, Kurt. Good morning, Lisa. Any words you would like to provide before we get started?
Just want to say good morning, everybody. Thank you so much for joining us. 373 participants and growing. We're so appreciative of your time and really looking forward to working through all of this with you. Thanks.
All right, Kurt, I'm going to hand it over to you. Welcome and thanks for being with us.
Yeah, of course. And now also want to extend gratitude. Thanks. Although Laura and Lisa, I don't know why you keep saying the number of people on the presentation. I was going to acknowledge that I've met quite a few folks here, but obviously not many of you. I'm fairly new-ish to my role. I joined the department in January and was a crisis provider and supervisor before that. So I haven't had a good chance to meet most of you. And I did see the number of folks on this. I've been in some big rooms, but there's something a little different about not being able to see everyone. So I'm just going to acknowledge I'm a little nervous. This is a new form for me, but I'm grateful to be here and grateful that everyone has joined, because we recognize the change that we're talking about is, as we'll get into, while it's a small administrative change, it's going to have big impacts on services, on providers, and on individuals. And so it's important to have the dialogue today and through the next few weeks and beyond. So I'm grateful to everyone for joining and hope that these 2 hours is productive. So what we'll cover, and I think I'm going to be with most of the airtime, for better or worse. So I'll do my best to inform, keep it moving, and maybe entertain here and there. but I'll move through just an overview of the crisis system, just kind of the level set for all of us. And then get into a summary of the upcoming process change on the 15th. From that, pivot to just an overview of what a regional hub is. And then we'll get into how we will support everyone and some of the training that will happen. We'll see a short video today that will begin some of the training, and then talk about the additional trainings and resources that will be following today. A bit of that is talking about the user roles within Virginia Crisis Connect, making sure that providers have the right roles on the 15th. We'll go DMAS shared a bulletin recently. Laura or Lisa will give a little bit of that. And then hopefully we'll have some time for some Q&A at the end. If we don't have time, as Laura said, we will share a combined document from DMAS and DBHDS with all the frequently asked questions. And we've been collecting questions. I've been talking with some of you and various stakeholders. A lot of us have, but had a handful of conversations. So we already have a good dozen or more questions that we know people are asking. And so that'll be the start of the FAQ document that we create, and any more questions that come from today or following today will include as well. So hopefully we'll have some time for some Q&A, but we won't get through everything. So we'll share more information afterwards. And then we'll end with some next steps. Okay, Laura's driving. I'm talking, she's driving. So a little bit of grace on the transitions here. So I want to start with a document SAMHSA put out in 2020, which was obviously not the first time that SAMHSA or others in crisis service provision talked about best practices and how we can shift the paradigm from what's historically been law enforcement emergency department-based crisis intervention to a community-based continuum of care. Crisis Now, I think we all know, is kind of the standard best practice, and SAMHSA put that into writing in this toolkit in 2020. Often we'll use the tagline, someone to call, someone to respond, somewhere to go. And this document, or this clip of a page of that document, it's a much larger document, but a clip of that page kind of outlines specifically what SAMHSA envisioned when they're talking about what the someone to call, someone to respond, somewhere to go is. Having a regional crisis call center, now 988 folds into that, but a regional crisis call center that has telephone, text, chat, and air traffic control qualities. Having crisis mobile response teams, and having crisis receiving and stabilization facilities. So the work that has been happening in Virginia as we shift this paradigm really goes back to these core services outlined in Crisis Now and the SAMHSA best practice. Okay, Laura. The next few slides, and again, I don't think we're breaking new ground on any of this, but I think it is important for us to kind of have context, have some shared context as we move into the rest of the talk today. The next few slides are, for lack of better words, kind of the Virginia manifestation of the someone to call, someone to respond, somewhere to go, how we're building these services in the continuum here. So someone to call, when someone calls 988, they get a trained crisis worker that can do that initial support, intervention, resource management, listening ear, which many times is sufficient to mitigate risk, to move the person to the next step. When that's not sufficient to resolve a crisis or to support the person in that moment, then we hit the someone to respond, which is mobile crisis response. Real time, 24 hours a day, to where the person is experiencing the crisis, as fast as we can to give that initial support on site and connect to services to support the continued stabilization after that initial crisis contact. And if that's not sufficient, then we have somewhere to go, which in Virginia is going to is manifesting in two services: crisis receiving centers, typically referred to as 23-hour service, and crisis stabilization units. Laura, I think we can move forward. I'll just kind of keep rolling. There's a slide that often comes around from Crisis Now showing how the different levels of care across the continuum can resolve crises and reduce the impact on inpatient services. And we all know that that individuals can enter or exit the continuum at various points. It doesn't have to start on the left and move across to the right of the screen. That said, each service is designed and able to resolve crises that come to them and be able to move the person up or down the continuum as needed if the service being provided is insufficient. So this is looking at what the Crisis Now calculator anticipates the various services being able to, the percent of crises able to be resolved by the service. The thinking here is if 100 people call 988, 80 of those will be able to be served well by the call center and not need an additional crisis service in that moment. But for the 20 that aren't able to be resolved there, mobile crisis is now a resource. And we get mobile crisis to the person as quick as we can, where they are with the resources needed to support them then. And the majority of those folks will be served well by mobile crisis, and that's sufficient in that moment. Of those 20, 9, however, may need further or more intensive treatment at a crisis stabilization site, CRC, or admission to a CSU. And of those, only 1 may ultimately end up needing hospital level of care. Now, this is going to, we see some early returns on the data, and it seems as if we're holding true. However, the services aren't all to scale, and our systems aren't all to scale, and so we anticipate some sort of ebb and flow in the impact of the various services as we build out. But the important thing is making sure that we have the whole system of care connected and integrated so that we can move a person up or down or respond to various services needed based on the crisis, how the crisis changes. Lori can go to the next slide. I think, in my experience as a crisis provider, and I don't think there's dispute on this, historically and I'm saying that in the broadest term, we are good at dealing with high risk, right? Hospitals, law enforcement, first departments. We're good at dealing with low risk, warm lines, support groups, community, peer recovery centers. Historically, it's been difficult for providers or for systems rather, maybe, to deal with that moderate risk because it's so variable, right? What's safe right now can change quickly in the next moment. And I think historically that means we've trended towards higher restrictive environments when we don't need to, if we can, from a systems perspective and from give providers what they need to handle moderate risk well. And to me, that's ultimately what this Crisis Now framework and these services and the system that connects them is going to be designed to do, to be able to safely and effectively serve moderate risk cases so that we don't have to trend towards higher acuity or higher restriction to mitigate risk. So this slide just kind of shows that we have things within our communities, varies from CPEPs and partial hospitalization programs over sort of on the higher, on the right end of this continuum, down to some community-based peer warm lines and support groups on the left, and the work that you all do and the services that we're looking to support and build and the infrastructure for it is to have a continuum that allows an individual in crisis to smoothly move along between services so that they can have the right service and risk mitigation in the community and reduce the burden on hospitals and law enforcement on the higher end. Okay, Laura. And a little bit about the roles and responsibilities. I mean, as we've said at the beginning, this presentation is a collaboration from DBHDS and DMAS, and we work very closely and meet regularly, and we have different roles and responsibilities in how we are moving this paradigm shift from where we have been in the past to where we will be in the future. And this is just to point out, and these are not the only code sections, but a couple key points in the code that requires the department or directs the department, DBHDS, to establish an infrastructure, if you will, to create the air traffic control that is going to the infrastructure that on which the crisis continuum will run. So that's our responsibility, and that's our charge, and it's underpinned even more so the last year with Governor Youngkin's Right Help Right Now initiative. Work streams 1 and 2, a third of this plan is all around crisis services. Work stream 1 is building up the services, and work stream 2 is reducing the burden of law enforcement. To me, they're one and the same. I happen to be the work stream lead for both of those, and we don't differentiate as a team, because by building up services, we will reduce the burden on law enforcement. So we've been charged by the General Assembly and the Code and by the Governor's Office to build this out and make sure the infrastructure and the continuum runs the way we all need it to serve each other and our neighbors when crisis situation arises. So I want to go back. This is a callback to one of the initial slides, and so where we get into now, talking about the topic of the day and the change on December 15th, is an evolution of the system to move closer towards having our call centers be the air traffic control hub that the Crisis Now model requires, and ensures that services are deployed in the most efficient, effective way across the Commonwealth. Okay, Laura. The 5 bullets here, on November 1st, DMAS and DBHDS distributed a memo that outlined the change that's going to be happening on December 15th. These 5 bullets are cut and pasted from the center of that memo and really get at the heart, or really are the change. And again, from our perspective, it is an evolution of the system to move us towards having air traffic control from the regional call centers, or from the call centers. So on December 15th, forgive me, I'm just going to read these out loud, because it really is the core of this whole thing. On December 15th, the 988 call center or regional crisis hub or their contractors will assess each call to determine if a mobile crisis response is indicated. Mobile crisis response will be dispatched only by the 988 call centers or regional crisis hub after that determination is made. Providers will not be able to register mobile crisis response cases directly in Virginia Crisis Connect. Providers of mobile crisis response will be dispatched to referral via Virginia Crisis Connect. And a mobile crisis response provider dispatched by the 988 call center or regional crisis hub to an individual will be based on provider proximity and ability to respond in a timely manner. In the short version, the dispatch coming from the hubs will generate the reference number required for providers. Okay, Laura. So a little bit about the regional hubs. Again, fitting with that Crisis Now model, we need our call centers to be more than just the place that answers 988. We need them to be able to manage the system, if you will. And so that's why we say regional hub. There are 5 CSBs that are the fiscal agents and administrators of the regional hubs. The call centers are contracted vendors, HopeLink, and 4 of the regions, Frontier Health and the 5th. But the roles and responsibilities are the same. And it's that they are the 988 regional line. So they take the calls, they screen the calls, they provide support there to individuals calling and needing crisis intervention. They have provider coordination and dispatch. So they're able to deploy mobile crisis resources to individuals where that's an indicated level of service, or coordinate with local PSAPs if the individual has a higher level or there's immediate risk to their safety or others. So being able to connect with PSAPs to get resources out. And then also care navigation and follow-up to make sure that folks have what they need after the initial crisis intervention. Hey, Laura. A little bit more context. There are 5 hubs within the state. This is a CSB map, but just to show that the boundaries of the hubs are based around the boundaries of CSBs, with 1 CSB in each being the administrator for hub activities. So Region 1, that is Region 10, terribly confusing. And Region 2, it's Fairfax Falls Church. Region 3, it is New River Valley and Planning District 1. They have some shared roles around managing the regional activities. Region 4, that's RBHA, and Region 5 is Western Tidewater. As I said before, Regions 1, 2, 4, and 5 have all contracted with PRS, which is now changing its name to HopeLink as the call center vendor, and Region 3 is contracted with Frontier Health. And it's important to note that Frontier and HopeLink have a very good relationship, and the hubs have a very good channels of communication between them. So the fact that there's two vendors doesn't, I don't think, creates any hiccups or kinks within the system. It's a pretty seamless communication between all 5 call centers and the two vendors. So in terms of,
I'm gonna interrupt you for a second. I'm really sorry. I just want to make sure that everybody understands and knows that the chat function is not being monitored, and all questions need to be put into the Q&A function, please. Thank you.
Laura, how does, as somebody who's also kind of new to WebEx, how does one get to the Q&A function as opposed to chat?
Ultimately, my screen looks different than the attendee screen. So most likely it's on the right side of your screen. There's either a more button or like 3 little dots you would press, and then it would give you the options.
I just asked you that question. Buy me 10 seconds so I can sip some water.
Thank you, Kyle. There are 3 dots. There are several people who have already put questions in the Q&A. If somebody wants to put the instructions on where they can find that in the chat, that would be beneficial.
Yeah, and I'll say too, I see sort of activity from the chat, and I see the dot on the Q&A. I'm just kind of rolling and paying attention to what I'm talking about. So if I'm not responding to people's questions or in the chat, it's not that they're being ignored. It's just that I'm kind of rolling through the content so that we can get to that portion.
Yeah, they are not being ignored. We are looking at them. The ones that we can answer, we will certainly answer at the end of the presentation.
Thanks. So now we'll roll through a little bit of how we're training, how we will provide some training and support as we move through this change, which again, in one sense, it's kind of simple is not the word, forgive me, a simple process change, but we also recognize that it is going to require a lot of training and understanding by various roles between now and December 15th and beyond. So this afternoon, we will send out a Calendly invite to folks for train the trainer sessions, which will be happening shortly. The dates will be on the Calendly invite. That will go to individuals. Well, let me back up. Last week, we sent an email to all organizations that have active MOUs with the regional hubs for mobile crisis providers provision. And we asked that each organization identify 2 trainers within their organization that can attend train the training session. From what we can tell, we've had a pretty good response to that email that we sent out to all the organizations with MOUs. If you have an MOU and you didn't see the email or it got lost, just reach out to us at crisis_services at PBHDS. We'll make sure the email address is available. So that we want to make sure folks can get signed up for the Calendly invite. So that email blast went out to everyone, again, that has active MOUs with the hubs. Thank you, Brittany. I do see that. That's the email address. So if you have individuals in your organization that need to be trainers and need to be part of the Calendly invite, reach out to us at the email address that was just dropped in the chat. The Calendly invite will go out shortly, and we'll set up those train the trainer sessions in the coming days. Sessions will, as it says here, they'll be approximately 2 hours long, and they're going to be conducted by Behavioral Health Link. I'll note that Behavioral Health Link, or BHL, is the vendor for Virginia Crisis Connect, and they are doing tremendous work, and their training resources will actually watch a short video here together that comes from Behavioral Health Link. But they are a tremendous resource to us and will be to you all as we move through this change and other engagement with Virginia Crisis Connect. Okay, Laura. There are some training resources already available on Virginia Crisis Connect through the behavioralhealthlink.com link there. Once you log in, on the left-hand side, the menu bar, if you scroll down to support, The top selection on support is guides. When you click guides, go to Laura to show you the next screenshot. When you click guides, then these two options come available, the SAS guides and SAS training videos. Under the guides, you'll see mobile dispatch user guide. It's a long document, but a very good one that has simple step-by-step walks you through all the pieces of Virginia Crisis Connect around how mobile dispatch or the various roles involved. And then if you go into the dispatch, mobile dispatch module videos, there's 3 videos there. We'll see one here in a moment, but they're all useful tools for folks. So you can go back to that guide and training videos at any time within Virginia Crisis Connect. Okay, now we'll do this video. It's around 12 minutes long. Do know that the sound doesn't start until around 6 or 7 seconds in, so it may seem at first that the audio isn't working. We went through that earlier. We realized we just need to wait a couple seconds and the sound kicks on once the video starts going. And I also note the sound may be a little quieter than the audio where you have as you're hearing me, so you may turn your audio up a little bit when the video rolls, and then once it stops, you may turn the audio back down so I don't blow your ears out.
Thanks, Kurt. I actually went through the video and the audio volume gets a little bit better around minute 2/3. Gets a little bit higher. But yeah, please turn your volume up as much as you can.
As a mobile responder, when you first log into your account, you will be prompted to enter in a default address. The form will ask for an address and a mobile number. Entering in
Sorry, everybody, that was me. I can't click on
your
anything.
mobile number will allow you to receive text notifications to your phone without having to have the application up at all times. The default address form will appear as blank fields the first time you log in, but after you enter in an address and select Save, the subsequent times you log in, it will prompt you to update your address if needed. Otherwise, you are able to select Keep Address. Once you have selected Save or Keep Address, you will be prompted to your waiting page. This waiting icon indicates that you are signed in, waiting for a case to be assigned to you. On the top right, you will see that your status is showing as available. This means that on the dispatch board, your account is active and available to send a case to. You are able to update your statuses, but please refer to your company policies about when and how to use these current status updates. If you need to make updates to your profile, such as a name misspelling, etc., go to the icon on the top right and select Profile. You will now have the ability to edit the fields in this form that are not grayed out. The only things that you will not be able to edit are the status of your account and your email address. If you are needing to edit these fields, please email support. All other fields you are able to click into and save. As part of improvement to system security, a new feature labeled Checked In, Checked Out has been created. When a mobile team member signs in and is available to accept a dispatch, they should navigate to the left-hand side of their screen and toggle this to ensure that it is checked in. Once this is toggled to checked in, the responder will be available on the dispatch dashboard to accept a dispatch. When a mobile team member is not available to receive a dispatch, they should toggle this to checked out. This will prevent the mobile team member from being shown as available on the dispatch dashboard. In the previous video, we discussed how to sign into your account and make updates to your profile. Once you have set your default address, this is the screen you will see every time you log into your account. Once you log in, you will be directed to your waiting page. This means that you are waiting to be assigned a case to respond. Please note on the bottom, there is a red box alerting you that you are currently waiting to receive a dispatch. You can simply select OK to close this message. Once you have logged in, please make sure your status is on available and you are in a checked-in status. When you receive a dispatch, you will be alerted on your account, and if your mobile phone is entered into your profile, you will also receive a notification via text. On your account, you will receive a notification on the top right that says, "Hi, your name, you received a new dispatch request along with the case code." When you have been assigned a case and pull up your account, this is the view that you will see. On this screen, you will be able to view information about your case and complete other functions that we will go over throughout this training. When you are actively on a dispatch, your status will automatically update to in dispatch. You will be unable to change that status. The information that is displayed under the dispatch request view is the information about the case, as well as a few buttons that we'll go over. As you scroll down, you will be able to see the name of the recipient needing mobile, the case code, primary and secondary presentation and concerns, the language, the address of where you are going, as well as the location type. If information has been entered in about guardian or representatives, you will be able to see on this screen as well. If you scroll up and select Go to Caller Info, you will be able to see the other side of the case. Once I've clicked into Caller Info, I will be able to see the name, date of birth, age, and recipient's phone number, as well as the mobile dispatch notes that were entered in. If you select Back, it will take you back to the main screen of the case, but you are able to toggle back and forth between the different views. Once you are back on this main screen, you are able to accept or reject the case that has been assigned to you. If you reject based off of your company's protocols, you will be required to enter in a reject reason. If you accept the case, that indicates that you're getting into your vehicle and beginning your navigation to the dispatch location. When you select Accept in Transit, the system will send a notification to the dashboard letting them know that you are now in transit. Every status will start a new timestamp. You are able to see your last status update timers on the back end of this case. To go back to the front of the case, select Back, and here you will notice you have a new status to select. Once you have arrived to your location, you will select Arrived, and as you can see, you now have a new timer started for your status. To go back to my statuses, I'll select Back. And you will be able to update your status as you progress through your case by clicking on the statuses on the bottom of your screen. Before we select Complete, let's go over some safety features. There are few safety features available to you as a responder on this application. Every time you are assigned a dispatch, these safety features will be available for you. The first feature is located on the top right, labeled Call for Help. If you select this three-line menu, you can select and Decide who you would like to call from the application. You can select Call 911, call the dispatch center, or request a call from the dispatcher. If you select Request Call from Dispatcher, it will send a notification to the dispatch dashboard to alert them that you need them to call. It will depend on your protocols who from the team will call you. In a case of emergency where you are not able to speak on the phone, you have an SOS button. By clicking this SOS button, it will send an alert to the dispatcher team to dispatch 911 to your location. The last safety feature is this check-in button. Selecting this check-in button lets your dispatch team know that everything is going okay. Your organization can set up time parameters where they would like you to check in. Failing to check in would alert your team that they need to attempt to reach out to you. An example of this would be if your organization has set a timer to check in every 20 minutes after you have arrived to your location. If you fail to check in on time or prior to that time, the system will send you a reminder to check in. If you fail to check in again, a secondary timer will expire and alert the dispatch team that you have not checked in. The dispatcher or supervisor will be able to call you to ensure your team is okay. Please always refer to your protocols about how to utilize each safety function. As shown in our last video, you have the ability of selecting your current status you are in by navigating to the bottom of the page and selecting the status. Again, as you select your specific statuses, a new timer will start to indicate how long you have been in that current status. As you go through, you are able to select all of your different statuses. When you have reached completion and you have finished with your assessment and you are getting into your car and going to be available to accept a new dispatch, you will select Completed, and then you will be navigated back to your waiting page to be available to be assigned a new mobile dispatch. As a responder, you will also have the ability to search for cases you did assessments for and add additional information. To locate the case, you will navigate to the left-hand side of the page and under Care Management, select Cases. Here you will be able to search via case code, recipient name, phone number, date of birth, and when it was created, as well as completing an advanced search to search for multiple of criteria at the same time. You will also notice that this page automatically opens up to open and in progress cases. If you need to see any cases that are in a closed status, you will be able to navigate on up here and toggle over to closed. Once you have located the case that you need to edit, you are able to come over and select this edit button. From here, you will be able to enter in additional information about the participant if demographic information has changed. But the main place that you will be entering information will be on your care planning section. When you get to your care planning section, you will notice that mobile crisis is automatically in action already. If you scroll down, you will then see you now have the ability to upload your assessment from here, as well as uploading additional referral files. Please note that your assessment file, you are only able to upload one file, but for referral files, you are able to upload as many files as you would like. Depending on your protocols, you are also able to change the status of the case to in progress or closed.
Thanks, Laura. So a big thing that we'll need to make sure is as we on the 15th that individual user roles are correct, so that people are able to do what they need to do and be dispatched. Bill, I see you came off camera, or came on camera, came off, back on. Bill, I'm going to call you out. Can you talk us through the role slides here? Yeah.
Sure. So you will get a few manuals. The manuals we are currently pushed out to the platform for a number of users that are trainer sessions. We'll be walking through the primary changes to your roles in the platform. So first, each agency, and we'll send out a spreadsheet to the trainers that we reached out to previously to find who mobile team members are for your agency, but also who is the provider admin for your agency as well. As admins on the platform will be able to add and remove users from your agency. We'll go into further detail at the trainer sessions or through the manuals of the platform. We can go to the next slide. A lot of roles. So with a lot of roles, there can be a lot of confusion that comes through that. You've likely seen this form. It's probably made it sounds distorted. I don't know how to fix that for everyone.
I'll jump back in. Sorry about that. I'm not sure why the audio is there was a little bit of echo there, Bill, for some reason. This list here, it's a list of all of the roles within Virginia Crisis Connect. It's a lot, and as Bill was starting to say, it's this list is available to folks. We just have it here really as just context to let you know that there are a lot of roles, but there are only a small number that are relevant to the change and to the what we're talking about in terms of mobile crisis dispatch and response. All right, Laura. So the transition of roles, as Bill says, is within the platform now, within Virginia Crisis Connect now, most are provider agents. But after the 15th, we will be switching to provider account admin and mobile team member. The trainings that will be conducted by Behavioral Health Link through the Calendly link, the email that we'll send out later today, they're going to be giving the information as to how we make sure that the appropriate people within each organization are changed to the appropriate roles, admins and team members, so that the system can work the way we need it to work.
That's me. Hi, everybody. Hopefully everybody's seen the bulletin that went out last week on the 9th. This really just iterates that we are requiring all providers of mobile crisis to follow the requirements of DBHDS, as well as all the things that are in our mental health services manual. There's going to be no policy change on the DMAS end. Our policy manual, Appendix G, already reports, which is number 1 here, the provider must engage with the DBHDS crisis data platform as required by DBHDS, which is what we've been talking about today. You need to submit your registration form with the generated reference number. You must have an active MOU with a regional hub. You must be licensed appropriately by DBHDS, and you must follow all of our other general requirements as well. So ultimately, there's no change on our end. The change is coming from DBHDS and how they're going to be managing the dispatching of mobile crisis. So keep doing what you're doing on our end in terms of the registration form, MOU, and all of those things that you will need to get paid.
So just to go back to what to expect next in terms of the trainings and how we move from here to the 15th. The training, I think this is a callback to a slide we showed earlier, but just want to reiterate, we'll send out the Calendly invite later today. That'll go to all the individuals who we now know to be trainers within your organization. So if, again, that email blast went to all providers who have active MOUs with regional hubs. So hopefully, if that's you, you got the email and it didn't go to an old address or someone who's no longer with the organization or a typo or whatnot. If you didn't get an email from us last week asking for you to identify trainers from the organizations and you have an active MOU, please email us at crisis_services, the email that was dropped in the chat earlier. Or if we need to get in touch with you, or we need to know who the trainers are, you need to make a change, or whatever the case may be, please reach out to DBHDS so we can ensure that the appropriate individuals in your organization get the Calendly invite to join one of the trainings that's going to be coming up from Behavioral Health Link and us. In that training, like we say, it'll be approximately 2 hours long, and it's going to cover what needs to cover for you to be able to support yourself and your staff so that you can be prepared for the changes that come on the 15th within Virginia Crisis Connect. Bill, maybe this is a chance to test the audio. Anything to add to that in terms of what folks can expect from us or from Behavioral Health Link regarding the trainings coming up?
Yeah, a chance to test audio again, but again, we will be sending out a spreadsheet to all of the trainers that were identified by your agency, asking for you to update who the roster for mobile team member is so that we can make the appropriate adjustments within the platform for the go live of December 15th.
Your audio is better that time. So good news there.
All right, well, we have come to the end of our presentation. There are quite a few questions in the Q&A. Thanks everybody for putting those in. I am getting a lot of private messages to myself about the presentation, the PowerPoint slides. As said at the beginning, the recording of this, there will be a link on our website, the DMAS website. After we go through the Q&A, I'm happy to share my screen around where you will potentially find that link. You can also find the recording most likely by the end of tomorrow, if all goes as planned. The recording on our YouTube channel, which is called Virginia Medicaid. Both DBHDS and DMAS will have links to that video as well as a PDF of the PowerPoint on our websites in the next coming days. So these will not be sent out individually. They'll be on our websites as a resource. So I've been looking through some of the questions, and we're going to answer these as a panel. Whoever feels most comfortable answering them can come off of mute and provide an answer. There are a couple of questions about community stabilization, and will this change to mobile change anything about community stabilization? The answer to that is no. There are no changes to how an individual would be referred to community stabilization. A mobile team, if they deem it necessary and feel like the individual meets the medical necessity criteria for community stabilization, can certainly put in a service authorization to the health plan for that service if they feel like that's needed. There is no change to community stabilization process at this time. The other questions I'm seeing are, will this change the amount of time that a team will get in order to provide mobile? No, it does not change the amount of time. The amount of time is in our policy manual, and you receive 8 hours of time within a 72-hour period. That is not changing. That will remain the same. The triage that occurs, and I'm sure Bill and Kurt can speak to that. Really, at this point, if you're dispatched, then the system is saying that that member meets medical necessity criteria to receive mobile crisis. So the triage is really what makes that determination. Once you all are dispatched as a team, that determination has already happened, and then you will put in your registration as you have been doing with the health plan. There are several questions about individuals being able to choose their provider. Is this going to change that? And I wanted to hand that off to Lisa and Bill and Kurt to discuss about provider choice.
Hey, I can kick us off with a few comments, and it's the question's kind of asked in a lot of different ways, so we'll make sure to get some good written responses out to you all. But there's a couple pieces I'll just touch on here. Number one, kind of to some of Laura's points, we're really looking, it's really just for this specific service. So for clients that are already in the care of your agency, did just want to note first that a lot of, for example, the Medicaid services, a lot of our services do involve a crisis intervention component. So there's, likely a lot of clients that are already in your care, already receiving a service. A number of our ART services require that 24/7 emergency service. Intensive in-home has the crisis intervention component. Mental health intensive outpatient recommends it. Mental health partial hospitalization requires it, as well as a few others. So for clients that you're providing a different service to, and they also have that crisis intervention component, I did want to make it clear that, that's not changing. This is really specific to that single mobile crisis service, which is that, initial touch point. So it's that response within 1 hour where someone is experiencing a behavioral health crisis and they need that assessment, right? So I think that's one also point I wanted to raise, which we'll talk about a lot, probably throughout a lot of these, is part of the mobile crisis service. So the service itself, what you would be providing once dispatched, is the assessment, right? So essentially the call center is not taking on that component of the service. That is still part of the Medicaid service. The call center is doing a screening and assessment to see, does the person meet criteria to receive the service? But really a really big piece of the service is that assessment. So the call center is really saying someone needs to go out and see this person face to face and do this assessment and really figure out what they need right now. Again, so it's doesn't mean that, there will definitely people that are already in services, already engaged with an agency will certainly, reach out for crisis services. But again, this is just for that one mobile crisis service where the idea is they need an immediate response within the hour. They need someone to come out there, almost like an EMT coming to a scene to provide that care. So it's really just that one service. It's not touching the crisis intervention that you provide as part of other Medicaid services. Like Laura said, not touching community stabilization, that slightly longer term crisis service that we have in the array. So those are a couple of the points I wanted to make. Definitely a few more. I'll see what Kurt and Bill want to add, and then I can jump back in if we have other ideas.
Yeah, I think I might, one thing you said, Lisa, I think that is correct, but I might say a little bit differently, is around the call center staff. I don't conceptualize what they're doing as doing a screening to find out if mobile crisis is indicated. I see them as trying to mitigate the individual's risk and provide them the support that they need with all the tools that they have in their toolkit. And they're well-trained individuals. The vendors that are running the call centers are great. And so if a person calls 988 and says, I'm very suicidal and I have a lot of intent and I have needs, that doesn't mean that call center staff is immediately going to hit dispatch mobile crisis. They're going to get some more information and they're going to provide some support, because sometimes, even though a call can begin with a high level of risk, that risk can be mitigated and natural supports can be brought into place, or there can be some stabilization, de-escalation in connection to resources the next day or whatever, to ultimately take what was a high risk situation and bring it down, bring it down a scale. But the call center staff have, within Virginia Crisis Connect, there's a module that they use that allows them to provide, input information that they get as they have the conversation with the individual. And if ultimately the tools that call center staff has at their disposal aren't sufficient to mitigate the risk, then we need something else, and the individual needs something else. And at that point, that mobile crisis would be indicated. So functionally, that's what they're doing, right? Is a screening to figure out, or a screening to figure out what level of care is needed. But that's happening as they're providing support and intervention to the individual and trying to identify resources they have and all the things that good providers do. And sometimes that won't be sufficient, right? And that's when the call center staff will kick that case to a dispatcher who reviews the case and then decides ultimately, yep, we got to get somebody out there. I'll also note, all that can be jumped if there is indication of immediate risk of harm to the individual others, right? They have means, intent, and they're standing on a bridge, or they have a weapon, or there's other people in the house or the place that could be, they can immediately engage with PSAP and get law enforcement there to ensure that the worst outcome doesn't happen. But provided that there is an immediate risk of immediate indication of something bad about to happen and the call center staff can engage the individual, they will. And if they can't mitigate the risk, they'll engage mobile crisis at that point. And then as Lisa says, when you would get on site, then there's that assessment that's required for the service. And I guess the last thing I'll say, and then I'll shut up and anyone can fill in nooks and crannies or more color. Lisa, you mentioned that essentially this is a behavioral health EMT, use slightly different language, but that's how I'm conceptualizing mobile crisis as the system continues to evolve. It's the generalist that responds in the moment for an individual that doesn't have other resources available to them, right? If somebody's already in the care of your organization or another provider and they have a crisis plan and that's sufficient, and that's where we're going to go. But it's for an individual that calls 988 and needs something right away and that other things aren't available, we need to dispatch a resource to them as quickly as possible, even if their preferred provider might be, if their preferred provider isn't available within an hour, we got to get someone to them right away, and then provide the linkage to the resources that they need after that initial touch point. If I'm in a car accident and I call 911, I'm not, I just want an ambulance to come quickly. And we're envisioning the mobile crisis response analogous to that.
Bill, do you want to jump in?
Just a few questions that seem to follow a common thread in Q&A. One, this doesn't have a substantive impact on emergency services, the TDO process, or ECO process. Those are not, emergency services would not be something dispatched to the platform. This is solely for mobile crisis response. Secondarily to that, I see a few functionality questions pertaining to, so one, if you're logged into the platform, you're logged in for an agency. If you work for multiple agencies, you can only be dispatched by one agency. That's just how it populates the mobile dispatch board. All providers who are in the platform are identified to be with a licensed agency. Likewise, the screening given by the call center, it's a risk screening that we have vetted through SAMHSA and Vibrant. It's gone through a rigorous process and meets all of their standards. We were the first state approved for the risk screening. We also continue to develop the resources available for the call center as well. Those are the biggest ones I see, but I've seen it a few times. If you have multiple responders in one agency, they will all show up in the queue, and it's based off geolocation. So if your responder is logged in by their phone at a different office than another responder, that wherever they are, their GPS on their phone registers them, that would provide them the closest location. So, and dispatches via location. Hopefully that answered a few of the questions.
Yeah, Bill, there's a lot of questions about the credentials of the individuals at the call center. Who's, what are their credentials? What's their training like in terms of being able to triage and assist individuals who call 988?
Sure. So the training at the various call centers, it's varying levels of skill sets that are coming into a call center to work there. However, it is 91 hours of training and I believe 40 hours of shadowing before they actually get into the mix of taking calls and start actually being able to make referrals. Every referral is then vetted by a clinician at call center as well before it's approved to go through dispatch. This is a pretty rapid process, but platform allows for the call center to have regular communication with their clinician and also trigger them to actually listening into the call. That'll then populate to the dispatch board where dispatchers will then identify the closest response agency or individual to respond to the person in crisis. I hope that answers the question. So the answer is the initial call, a wide range of skills. It still goes through a clinician before it hits dispatch. And typically the clinician is either taken over the call or start listening into the call before it gets there.
And I'll add to that too, that kind of harkening back to what I said a second ago, the call center module within Virginia Crisis Connect is also, it's built on that SAMHSA and Vibrant Approved Risk Assessment that Bill mentioned. And so the call center staff are well-trained and well-supported, and then that resource that they use as they're working with the individual helps guide their conversations and questions and engagement to ensure that they're providing the individual all that they can, and that they're well aware when they hit their ceiling and need to bring in other resources to serve the individual well. So it's not really just left to the individuals, the call center staff's this full discretion. They have tools and resources to help them guide what how they're engaging with the person, and then when they pull in the dispatcher or supervisor to determine best next steps.
Hey, Lisa, I know that you wanted to potentially say something, but before I say that, there are several individuals saying that there are pending questions in the Q&A. We have hundreds and hundreds of questions in the Q&A right now. We're not going to be able to get to all of them. So please be patient with us. That the FAQ that we are going to develop will help with the questions, and that will be coming out in the next couple of weeks. So please be patient with us. We may not be able to get to all of the questions. There are several questions about 23-hour observation. Or crisis stabilization. There's nothing changing with 23-hour crisis stabilization in terms of being able to refer to 988 or mobile crisis services. Anyone could call the 988 number, and if they feel like there's a need. So. Lisa, is there something that you'd like to say?
Yeah, it won't necessarily. It's sort of touching on a lot of different kind of detailed process questions, but just sort of a general comment about them. So what we're describing today is we're here representing the state agencies, and there's a number of contractors and vendors involved in this, and so so we're looking at the services and the very, very general referral pathways. But a really important piece here is that the way that Virginia has set this up is through a regional approach, which is, so it's not just a single call center and it's not just a single dispatch. We have the shared, that's a lot of what we're talking about here is sort of the data piece of it. So this ability to dispatch and use the platform. And that's kind of our perspective as the single state agencies. But a lot of the questions that you all have, I'm seeing some detailed ones about, okay, if we're kind of interacting with a client somewhere and, we would like to have them call 988, so in one way, there's a simple answer, right? If you're the closest provider, then you'd probably be the closest provider if you're in a room with them. But the point I wanted to make was more so about the role of the regional hubs. So this is going to look a little different within each region. And some of it's, more technical details around the operation of dispatch and the role of the mobile crisis hub. But a lot of these, some of that fine grained piece, that's really the strength of the regional approach, that a lot of the relationships and what the processes look like and exactly how some of the pieces work. Some of that you're going to get through your interactions with the hub, so we're definitely doing our best to keep it to do what makes sense to keep standard at the state level. We're doing what we can. We think the data infrastructure piece, obviously the service definitions are standard across the state. We're doing what we can to think critically there. And the regional piece of how a lot of this looks on the ground, I did just want to make sure to highlight that as you build as from the provider perspective, as you build your relationships with the regional hubs, some of these really detailed pieces will live a little bit more there than they will, for example, in the DBH, the sort of the policies that are written into our manual. So just wanted to highlight that. If you, depending on, your level, I know all providers are under memorandums of understanding with their hubs right now, but I know those relationships are will continue to grow at this point.
Yeah, and thanks for that, Lisa. I think that's a good point to make. And we're working with the hubs themselves, and I've asked that they help coordinate hub level or regional level meetings with private providers. And I know some of those are either already scheduled or scheduling in the works, because as Lisa pointed out, some of this is sort of state level system and stuff, and some of it's regional level process, workflow, relationships, pathways, that kind of stuff. So this is an important first conversation, but we also want to help facilitate and support regional level conversations that we'll be part of, but working with the hubs to make sure that we have those additional trainings and conversations.
So there have been a couple questions about reimbursement in terms of not having or not being an in-network provider for a health plan. I just want to mention, and this is stated in our bulletin, that ultimately for Medicaid, it does not matter whether you're an in-network provider or an out-of-network provider for a health plan. If you were dispatched for mobile crisis response and the member meets medical necessity criteria, you would send that registration to whichever health plan that member is assigned to, and will receive reimbursement if you meet all of the criteria and do all the things that are in our manual. For emergency and crisis services, it is not an option for our health plans not to pay if you are not credentialed or an in-network provider. Bill, there's still a lot of questions about how it's determined which provider is dispatched. I know you talked about geolocation, but there are several questions around, is that based on the office address or actually physically where the mobile crisis team is located in the moment?
Yeah. So your plot on the dispatch board is based off your cell phone being logged into the platform and the GPS coordinates of your cell phone, and making sure your cell phone's not on Wi-Fi for instance. So we get a true location. There, as you likely saw in the video, there's a default location you can put in for your office, but it is going to be based off where your cell phone is currently pinging a tower. That way we can make sure that we're dispatching the team that is closest to the individual in crisis and therefore the fastest response. If a team does not accept the response and had been dispatched, we're working on timers right now that would then move to the next team in relation to the quickest response.
Thanks, Bill. Let's see, questions about, will residential crisis stabilization be affected by these upcoming changes? The answer to that is no. see questions about telehealth assessments. Are they still allowed? Please refer to Appendix G of our Mental Health Services Manual for Mobile Crisis. That will tell you what is allowed. But yes, they are still allowed. Bill, does every mobile team member need a profile?
Yes.
Question, can police only be dispatched through the app?
No, there's a transactional relationship between our call centers and local PSAPs 911 answering points. If the need for law enforcement was observed or indicated, we would then, through the call center, through the dispatch function, pull law enforcement into the situation.
Question, are QMHPs able to be dispatched, or are licensed individuals the only people that can be dispatched for assessment purposes? Bill, do you want to tag team that one?
Yeah, I mean, there could be a team, and this may be where I walk back one statement. So if your team is composed of a licensed individual and QMHP, and that was your tandem response, then it could be that your licensed individual was the one displaying on the platform. It's incumbent on your agency to be able to determine what the appropriate team response is. I would say you have a wider net if both of your team members are logged into the platform, as far as geolocation being available. Maybe they're not at the same place, but they can move. So it's to your advantage for everybody to be in the platform so we can more easily identify what the team approach could be. But that being said, you would want your licensed individual to be on there if they're going to be working in tandem with a QMHP.
So ultimately, from a DMAS perspective, a licensed mental health professional always has to be involved, no matter who's dispatched. The assessment has to be signed off on by the LMHP, and the LMHP has to be face-to-face, either via telemedicine or in person for at least a period of time in order to sign off on that assessment. There's a lot of questions about the registration form. The registration form can be found on our website where all of our forms are located. It is underneath the behavioral health section of our website. There is already a section on the registration form for the reference number, and mobile crisis teams should have been putting that number on the registration form since the inception of mobile crisis in December of 21. If there are concerns about that form, you can certainly email us directly at our divisional mailbox. There are a lot of questions, Bill, about, I think, not the train the trainer training, but the actual sort of training of mobile crisis teams that has been going on over the past 2 years. Questions about trainings being full and not being able to get in, and general questions about, when there are going to be more trainings being held for teams. Do you have any response to that?
I would have to consult with our hubs and our services office to be able to have a better response to that. I've been solely focused on the training associated with this platform component. We can try to include something in the FAQ.
Yes.
Sorry, I'm looking through the questions, guys. There are several questions about commercial insurance. I think some of you are aware that there is legislation that is requiring commercial insurance to cover mobile crisis response as of January 1. The questions concerning commercial insurance are not something that we can answer on this webinar.
I will say, for what it's worth, we, I mean, as Laura says, that's not this webinar, but we have been in communication with the plans and Virginia Association of Health Plans to just consult and liaise with them as we move towards January 1st to prepare them and to get the information we need to help support providers as well. So more information as we have it to help everyone be ready for that that change on January 1st.
Bill, there's a question, will the provider admin be able to see who is checked in at all times on the
Yes.
platform?
Yeah, so that they should be able to monitor their staff on the platform. We're working on dashboards for them to be able to have also monitor the check-in, check-out times for their staff as well.
Laura, I can jump back in. There's still more questions. I think there's still people want more follow-up information regarding, sounds like clients that are already being served by a certain agency, and what how that is going to interact with their access to mobile crisis service. And so we'll continue to work through more information to give to you. You know, we already talked a little bit about the other the services that if someone's already opened up to, they could be there's already a crisis intervention component that your agency would be providing. Again, none of that's changing, none of that's going through through the call centers. Another piece that we didn't mention is the psychotherapy for crisis as something that could be built again for cases that you're already serving. And you know, it's the person would want to, you know, stay with their current provider. Psychotherapy for crisis would be another piece to consider. And then also just wanted to you know, think back kind of one of Kurt's earliest comments that the function of the call center is not, you know, to screen people. It's really to provide a lot of you know, to provide support, talk through what's going on, and provide, you know, a number of things. Another big piece of that is really those resources. And so, right, that's when the person would be having that conversation of, you know, I'm already receiving this service from this provider, and, you know, and kind of talking through how some of those pieces would connect, for example, to things like community stabilization and, you know, just kind of starting some of that care coordination piece. You know, part of that would also be related to the to what happens during the phone call when they're receiving that general support and that care coordination, and, you know, are you already under the care of an agency and things like that.
There's still a lot of questions about, does this process pertain to the other crisis services? And the answer to that is no. You're only currently discussing mobile crisis response. This process does not pertain to any of the other crisis services. There's still a lot of questions about telehealth, and I just want to reiterate that this is although telemedicine, which is simultaneous audio and video, is able to be used for the assessment portion of mobile crisis. The rest of the mobile crisis response is a in-person, physically in-person response. So this is a physically in-person response service. The only things that can be done via telephone or care coordination, and the assessment has to be done and completed and signed off on by the LMHP with the assistance of whoever else is on that team. The LMHP has to see the individual face to face, whether that's via telemedicine, which is simultaneous audio video, or whether that's in person. So Bill, there's a question. So if the preferred provider doesn't respond within an hour, they would be sent to another provider, question mark?
Much lower than an hour. So the mobile dispatch team would be monitoring that situation. If it's the situation of a provider accepted and like got stuck in traffic, there would be a check-in process from the dispatch to the provider to see what's going on, if the case needs to be moved on. If the individual was dispatched but did not respond, did not accept the dispatch, it would then within minutes move to the next dispatch provider.
Yeah, and the call center agent will stay on the phone with the individual until the provider gets there, right? So it's not just a dispatch and then drop the case. So if there's some hiccup or change in the situation before the provider is able to arrive, the call center can manage that. Again, part of the air traffic control, if you will. And like Bill says, there's a if I get a request to dispatch but I don't pick it up within a time, then it'll go to the next person. Or I do pick it up, and then, as Bill says, there's some mitigating factor. I'm stuck in traffic, or heaven forbid I get a car accident or a personal emergency, and I can't go. I can get back on the app and reject it. And say I thought I could go and I can't, and the hub is able to immediately dispatch the next provider that's close. So they stay engaged with the case until the provider arrives and begins doing their work and can pivot, because sometimes we need to pivot.
So Bill, there's a question. Any concerns about this process in the rural areas where internet is not that great? Does this dispatcher call providers or just send the notification?
Well, this notification could come in two modalities. So it can come via the actual interface on your phone to a data connection, or it can come via text. If there's difficulty with that, then we can move further downstream with direct phone calls. Likewise, the app, which go live in January, would allow Wi-Fi usage of as well to help resolve some of those location issues.
So there's a lot of questions about will the call center be determining the individual's insurance and getting authorization. The answer to that is, well, I'll let Bill answer that.
I mean, we'll determine to the best of our abilities, but the bigger issue is actually dispatching the team to an individual in crisis within the community. To the best of our abilities, we'll identify insurance information, but that's if we're capable of doing so.
So there are a lot of questions being put in the chat, and I have said several times before, that all of the questions need to be put into the Q&A and the chat is not being monitored. We're doing our very best to answer all the questions that we're able to answer. This is a question. What is the difference between the call center and the regional hub?
It's a good question. I'll take a crack at it, and then anyone else can add. Functionally, I think functionally for our purposes here, not much. The regional hubs, you know, we said again, they're the 5 of them are each housed within a CSB and are under contract with the state through the performance contract and exhibits to that general performance contract between CSBs and the state to do certain things. They have certain roles and responsibilities. One of those roles and responsibilities is, in this instance, is to act as a regional hub and provide that air traffic control and run the call center. They have all then contracted out that call center function. So for us, we have a contract with the hub to have a call center and provide the dispatch and air traffic control, and they have each contracted the call center functionality with, again, HopeLink or Frontier Health, depending on the region. Across different regions, the dispatch function might vary. In some regions, that dispatcher is a staff person of the call center vendor. In some regions, it's an employee of the regional hub. But the roles and functions, the workflows are the same. They function the same. So that's why the language on that memo said regional hub or call center, just because that dispatch function varies. But for the expectations of the state of the hubs is the same, that they operate call center and the dispatch function, the air traffic control function that's required for this, the infrastructure.
So this is the question about current contracts with MCOs and will that contract be valid for the commercial side of the insurance company? That's a really good question. And I just wanted to let you all know that we've clocked that question. I think the answer is most likely no, but ultimately we'll make sure that gets on the FAQ.
I see one, has this system been successfully utilized in other states or areas? And so I think that's a good question, and a couple of points I'd like to make. So yes, with all of this, you know, the Crisis Now model, the implementation of crisis services, all of these best practices that are what Virginia legislated when they implemented this system, although it has taken some time for the infrastructure to come online. Yes, these were based on successes in other states, systems that states have set up in response to situations, you know, such as settlements with the federal government under Department of Justice and things like that. And so I know 2 of the big ones that that we often point to are Arizona and Georgia. And so yes, I mean the model includes the air traffic control for the mobile crisis service. I think that what we did in Virginia is unique in that we did add another service. So there are the 3 services that are the Crisis Now model, the mobile crisis response, and the 23-hour, the someone to call, which we didn't write into that, which is through the 988 call centers and the regional hubs, the mobile crisis response, and then the place to go for observation and crisis stabilization. You know, 2 things we've done differently in Virginia. Number 1, our mobile crisis service is very extensive. If you look to other states, you're really looking at a 90-minute interval, maybe 2 hours, maybe 3 hours. What we're looking at to 8 hours over a 72-hour period is a very extensive service that was really designed that way based on stakeholder feedback. The idea that you might need to follow up multiple times, it might take a little bit of time to get people into services. And then the same thing with what we consider our transition service, community stabilization, which can be a slightly longer term service and can bridge the gap between someone experiencing a crisis and someone getting into, a good care plan with a provider and, receiving the supports that they need. So yes, I think this is how the model that Virginia legislated and directed, this is how it works. It works through the air traffic control dispatch system. And then I would say the two notable tweaks that make what we've set up in Virginia a little bit different is the longer interval for the initial response, and then also the addition of the fourth service.
Bill, can you discuss again how a provider is chosen to be dispatched?
So primarily, it's based off proximity to the individual in crisis. So when their address is volunteered, this is a consent-based service. When their address is volunteered, we push it it is input into our system. It pushes to a mobile dispatch board. Going back to that map and that queue that we showed earlier in the presentation, from that board, it is intended to be that the person of closest proximity is then dispatched, and we go through that list.
Bill, will the trainer replace the mobile crisis training that is required?
No, the trainer training is primarily just the nuts and bolts around how to navigate how you receive a mobile dispatch, how you respond, button pushing that goes along with that. It's primarily use of the system. It's not replacing the mobile crisis response training.
And a team decline a case and it be reassigned to someone else in the provider's agency.
Say that one more time. You broke up when you asked the question.
Sorry, it says, can a mobile team decline a case and can it be reassigned to another team within that agency?
It would depend on the proximity to the individual. So, I mean, if we were to say Laura declined the case, but I work at the same agency, but I'm an hour away, 30 minutes away, even 15 additional minutes, it's a person who's in crisis in the community. Again, it's trying to get the fastest response to the individual.
If you move your location throughout the day, do you log in each time to change your location?
As long as you're logged in for a shift on the platform, it'll just follow you as you move around through the day. So if you're in transit and someone looks at the mobile dispatch board, it sees that you're in transit until you log off.
The individuals responsible for obtaining insurance authorization are the providers, so the specific mobile crisis teams, the agencies that are responding.
Couldn't hear that.
You didn't hear me?
No, I didn't hear you.
Oh, sorry. I was making a statement. Somebody asked about who is responsible for getting insurance authorization.
Sorry.
And it is the individual agency that is being dispatched. Will the dispatch center refer clients to a lower level of care? How is that process managed?
Sure, call centers definitely refer people to a lower level of care on a regular basis. By the time it's gone through the dispatch, it's already been vetted through the call center. We're also enhancing the referral capabilities of our call centers by doing an integration with all of the 211 resources in the state, as well as local resources being available for call centers to update the platform as well. So yes, at the point of call, there's ample opportunity to refer to lower level services.
So I'm reading through a lot of the remaining Q&A, and I know for some of the ones that I'm still seeing, I know that for us, we're gonna want to do a little more research, talk to the different hubs, make sure that we're getting you the best information in terms of some of the really detailed ones, and then also some of the broader ones. So I know I'm going to want to work on some of our responses for some of the DMAS ones that are still there. And maybe also mention with that some of the ones regarding the other states and things like that. Looks like some more came through after my last comment. And did just want to mention that, yeah, for the states that have implemented this, it is a very long process. They'll say 10 years, more than 10 years. Virginia has been on this path for a few years now, but it is going to take multiple system evolutions for us to really have in Virginia what you would consider a comprehensive crisis system that folks can access and then get linked to the proper level of care. So it is. This is a big change, and it also is, one in what will likely be a number of evolutions of the system for Virginia to ultimately have, what would be considered a comprehensive crisis system.
Yeah, I want to jump on that a little bit too, Lisa. We recognize that this change on the 15th is going to have a lot of impacts for you, a lot of impacts for the providers, a lot of impacts for the hubs, a lot of impact for the call centers, for us, but mostly for individuals seeking crisis care. And the intention is not to restrict providers' abilities to serve people well. It's to further evolve our system so that we can ensure that every Virginian has access to care and that we can manage that care through the air traffic control. And a critical piece of that, as Lisa just suggested, is the data, right? So that we can further refine the system and evolve the system so that people get the care they need it right away. And so this change on the 15th isn't the end of it, right? As we've mentioned, Virginia Crisis Connect many times through the last hour and 45 minutes. And that system gives us a lot of information, and we'll be collecting and monitoring that information. We'll make as much transparent as is appropriate and possible so that we can see how the system is functioning. And we'll evolve it again and again as needed to continue to refine it to ensure that it runs statewide. So it's not to have preferred providers, but to make sure that there's an infrastructure that all the providers out there can do good work and serve people well. But again, I recognize that changes and shifts like this come with complications and difficulties, which is why we want to have this conversation and have the training available and make sure that VHL is available for the technical resources, that DBHDS staff is available for the support for providers, DMAS is available to make sure that reimbursement continues to happen as it can. And like I say, we'll have conversations with VHP to help as we move towards the January 1st change so that private plans can become a critical player for providers as well.
So I just wanted to thank everybody for coming today. I know it's been a lot of information, and we appreciate you being here. We are collecting all of the questions that have come in, and we'll be developing an FAQ. That FAQ, we are slated to have at least an initial FAQ out before Thanksgiving, and that will be posted to the FAQ section of our behavioral health website, the DMAS website. So if you're not familiar with that, please go and look at that section. You can always email us at enhancedvh@dmas.virginia.gov, specific to policy questions that are in our mental health services manual. We will only be answering those questions in that email, and you can certainly contact DBHDS Crisis Division at the email address on the screen. However, I will say that if you have asked a question in the Q&A, we will do our best to address that in the FAQ. So you do not need to resend those questions to these mailboxes. All right. Kurt, Lisa, anything else you want to say?
No, just thank you. Thank you everyone for the time, for the discussion, and it won't end at the end of this meeting. We'll keep it going.
All right. Thank you guys. We appreciate your time, and we'll be in touch soon.